welcome you all to the third IPNA Endorse Webmaster Series 2022. The topic for this webmaster is tubular diseases, and we started our symposium on July 9th, and we have symposiums going on twice a week on Wednesday and Saturday up until August 17th. This is the fourth webinar in the series, and this would be on evaluation of Bartter syndrome and evaluation of tubular disorders. As you know, there is polling sessions with this webinar. With the symposium, the polling sessions would start from Saturday, which is July 23rd. So please let your trainees know they would be joining these polling sessions. All the instructions for the polling sessions will be given 10 minutes in advance. So please attend these sessions, and there is some cash prizes associated with it. There is CME credit hours, which is going to be given with each webinar. So please look out for your certificates as well. To start, today's session, first of all, I would like to welcome the moderator of our session, Dr. Kanav Anand. Dr. Kanav is a consultant in the Division of Pediatric Nephrology and Renal Transplantation at Sir Gangaram Hospital in New Delhi. He is recipient of National Award for Excellence in Healthcare in the field of pediatric nephrology, and he has received multiple awards as well. He has presented more than 75 oral posters and papers in various conferences, both nationally and internationally, and won awards for the same. He has also authored a number of chapters in the books, both in pediatrics and pediatric nephrology. Please welcome Dr. Kanav Anand. Over to you, sir.
You're muted, sir.
You're muted.
Yeah, can you hear me now?
Yeah.
Yeah. So thank you very much, Dr. Jain and Dr. Namalwan and Dr. Kalevani, who's the organizers, for inviting me for this seminar. So very warm welcome to all of you. So today's tubular disease symposium, we are going to focus on evaluation of a child with Bartter syndrome and evaluation of a child with suspected tubular disorder. So both of them is very important from a practicing pediatrician's perspective, because if you pick up tubular disorders in time, definitely it's going to go a long way in terms of the initiating of therapy and your long-term prognosis. So to present the evaluation of child with Bartter syndrome, we have Dr. Sriram Krishnamurthy. So he's an additional professor, Department of Pediatrics, JIPMA Pondicherry. He has a specific academic interest in glomerular nephritis, acute kidney injury, caput, nephrocalcinosis, and urothiasis. And he has multiple publications to his name, and is also a working group member for ISPN guidelines on HUS and nephrotic syndrome. So without wasting much time, so over to you, Dr. Sriram.
Dr. Sriram?
Yeah, I'm logged. I'm just sharing the slides.
Yeah.
Can you see the are the slides being seen?
It's not in slideshow.
Okay. Okay. Thank you, Dr. Kanav, and thank you all the organizers for the kind invite. I'll be speaking on evaluation of a child with Bartter syndrome. So the specific learning objectives of this talk are to understand the clinical manifestations associated with Bartter syndrome. And with the help of clinical case-based scenarios, I will try to illustrate the wide diversity in the phenotypical spectrum of Bartter syndrome. And one should also be aware of the differential diagnosis of Bartter syndrome, conditions that mimic Bartter. So we'll be talking about them also. And management and outcomes of Bartter syndrome in children. So in 1962, Bartter et al. Described two African-American patients who presented with hypokalemic metabolic alkalosis with renal potassium wasting. They had JG apparatus hypertrophy, normotensive hyperaldosteronism, and high plasma renin activity. Over the years, the phenotypical variants of Bartter syndrome based on age of onset, severity, the urine specific gravity, hypomagnesemia, and hypercalciuria due to involvement of various different channels in the different nephron segments have been described. And usually Bartter syndrome is autosomal recessive, except the type 5 Bartter, which is major 2 mutations. These are X-linked recessive, and the formerly called Bartter syndrome type 5 due to calcium sensing receptor mutations are known to be autosomal dominant. This has been now separated out as a separate entity and known as familial hypocalcemic hypercalciuria. It mimics Bartter, but it's not, according to the OMIM, anymore Bartter syndrome. And then we also need to understand that genotypical information is important in Bartter syndrome, but mostly a weak genotype-phenotype correlation has been reported. So to understand Bartter syndrome, we first need to know some basics, which are the salt absorption in the thick ascending limb of the loop of Henle, which is about 10 to 20%. And this is primarily mediated through the NKCC2 channels in the luminal side of the thick ascending limb of the loop of Henle. And here you also have the KCNJ1 channels, which encode the ROMK channels. The gene encodes the ROMK channels. And these are responsible for pushing out the potassium into the luminal side. And on the basolateral side in the TAL, we have the CLCNKA and the CLCNKB channels, which have Barton as a subunit, a cofactor. So a mutation in any of these can produce Bartter syndrome. NKCC2 mutations lead to Bartter syndrome type 1. The KCNJ1 channels, which encode the ROMK, these any inactivating mutation in them will lead to Bartter syndrome type 2, which has a transient hyperkalemia, at least in the neonatal period. And the CLCNKA and the KB, when you have both mutations, this will be known as 4A. If you have only CLCNKB mutations, it will be class 3. And if you have a Barton mutation, then it will be class 4A. The basolateral side also has the sodium potassium ATPase, which is responsible for absorbing 3 sodium ions into the bloodstream in exchange for 2 potassium ions. So what is also important to know here is the luminal potassium concentration is the main driving force for the paracellular uptake of calcium and magnesium. And this is facilitated by a lumen positive transepithelial potential. So therefore, you will come across hypercalciuria and hypermagnesiuria in patients with Bartter syndrome type 1 and type 2, and also in type 5. Apart from the thick ascending limb of loop of Henle, the salt transport is also there in the DCT, and this is to the extent of about 5 to 10%. The main channel here is the sodium chloride co-transporter on the luminal side. And you also have the CLCNKB here also, along with the Barton. The same sodium potassium ATPase is there here also. And you have a sodium magnesium exchanger and a sodium calcium exchanger. And in addition, the calcium and magnesium, they are actively reabsorbed through the TRPV6 and the TRPM6 channels respectively. So the potassium is immediately recycled and pumped out of the cell by the basolateral potassium channel KCJN10, and mutations of these KCJN10 ultimately lead to the East syndrome. And the calcium and magnesium are imported by the TRPV6 and the TRPM6 respectively. So having known how the sodium gets reabsorbed in the TAL as well as the DCT, let us see at the subtypes of Bartter syndrome. Type 1 is due to mutations in the NKCC2. Type 2 is due to mutations in the ROMK gene. Type 3 is due to mutations in the CLCNKB located on the basolateral side. Type 4 is due to mutations in the CLCNK A and KB. When it depends on if you have both of them mutated, then it will be Bartter syndrome type 4B. Whereas if it is only a Barton mutation, it will be 4A. And as I told earlier, the calcium sensing receptor mutations are now separated out from Bartter syndrome, and they are classified as autosomal dominant hypocalcemia with hypercalciuria. So irrespective of the type of the mutation, whether it is type 1, whether it is type 2, whether it is type 3, 4A, 4B, ultimately what leads is that there is defective sodium chloride transport in the TAL. This leads to increased sodium chloride delivery to the distal nephron. It also leads to impaired calcium and magnesium paracellular reabsorption, which is mediated, for example, through the claudins. And there is impaired tubuloglomerular feedback with abnormal volume sensor. And this ultimately leads to increase in the prostaglandin synthesis and afferent arteriolar dilatation. And if there is polyuria, it will ultimately lead to volume contraction. Volume contraction leads to high renin, high angiotensin 2, high aldosterone, and ultimately potassium gets excreted. This potassium, ultimately when there is hypokalemia, you get metabolic alkalosis. So this is how the various gene defects and the pathophysiology in Bartter syndrome are linked. So there is a subset of Bartter syndrome in which no genes are identified yet. And these may in the future give us some more insights into what other kinds of Bartter syndrome are there. So why is there metabolic alkalosis in Bartter syndrome? The classical view was that increased sodium loss in the urine stimulates the proton excretion in the urine via stimulation of the vacuolar type H+ ATPase. But the recent views are also like there, for example, in type 1 Bartter syndrome, which is due to the NKCC2 mutations, there is sodium hydrogen exchanger 3, NHE3 stimulation in the TAL. This stimulation is ultimately because of the NKCC loss of function. So you get metabolic alkalosis. And similarly, type 3 Bartter, which is the classical Bartter, it has a CLCNKB loss of mutation. This leads to loss of function of the type B intercalated cells. And these type B intercalated cells also secrete bicarbonate. So that is why you have a higher metabolic alkalosis in Bartter syndrome type 3 than in the other types. So these are all some other recently proposed mechanisms why metabolic alkalosis ultimately occurs in Bartter syndrome. So let us see once again. So you have the 5 varieties of Bartter syndrome: type 1, 2, 3, 4A, 4B, and 5. And so what you would see is nephrocalcinosis. And so nephrocalcinosis is most common in type 1 and type 2. And these are the antenatal varieties of Bartter classically. Babies are often born premature in this. There is polyhydramnios. And type 2 is additionally characterized by a transient hyperkalemia, which can lead to some confusion with the diagnosis of pseudohypoaldosteronism type 1. Whereas type 3, 4A, and 4B, type 4A and 4B, these are classified as antenatal Bartter syndrome with sensorineural deafness. Whereas type 5, major 2, this is a transient Bartter syndrome. It may be accompanied by nephrocalcinosis, but it's the best in prognosis. You may outgrow the disease. And type 3 is the most variable and confusing type of Bartter, which can have a antenatal presentation also. It can have a loop type of presentation also. It can have a DCT type of presentation also. So type 3 is the most confusing variety and the most widest spectrum variety among all the varieties of Bartter. Type 3 is classically viewed as classical Bartter, but you can have antenatal presentations even in type 3. For example, there is a subset of type 3 where polyhydramnios is reported. Type 4 has sensorineural deafness. It has severe growth retardation, and it is supposed to be the worst in prognosis. It progresses to end-stage renal disease faster, with some exceptions. It is generally poorly responsive to indomethacin, and you may have fever, vomiting, and bacterial infections. Type 4 may also have severe hypomagnesemia. Occasionally, type 4 may have a very late presentation, because a presentation as late as 28 years has been reported with very mild manifestations. But these are exceptions. Generally, type 4 would be classified as antenatal Bartter with sensorineural deafness. So now, should we go by the genetic classification, or should we go by a newer proposed classification, which is based on the physiology? So according to this new proposed classification by Sabert et al. In 2008, so what has been told is there is a loop phenotype, there is a DCT phenotype, and there is a combined phenotype. So instead of a genetic based classification, these people have proposed this kind of pathophysiology based classification. So the loop phenotype, in this you will have type 1 Bartter and type 2 Bartter, which is the NKCC2 and the ROMK mutations respectively. These have an antenatal onset. These have prematurity, lot of hypercalciuria and nephrocalcinosis. Whereas the DCT phenotype is characterized by CLCN-KB, and the CLCN-KB, that is the classical Bartter, would fit into this, and then the Gitelman syndrome would also fit into this. This would not have hypercalciuria so commonly. It would be more characterized by a hypo or a normocalciuria. Hypomagnesemia indicates a DCT phenotype. This has a much later onset in childhood classically. The combined phenotype is the BSND, which is Bartter syndrome type 4A, or CLCN-Ka or KB mutations, which are 4B. So these have an antenatal onset, they have severe symptoms, and they have a variable calcium excretion. So should we follow this pathophysiology-based classification instead of the genetic-based classification? What are the pros and cons of these types of classifications? Let's see. So the gene-based classification is very appealing to neonatologists because it helps them deal with complications in the first few weeks of age. However, the cons of this is that Bartter syndrome type 3 can have an antenatal onset, and vice versa is also rarely true. So there are flaws in the genetic-based classification. The physiology-based classification is more appealing to pediatric nephrologists, and because Bartter syndrome is a disorder of the TAL, while GS is a disorder of DCT. So some people say why you should be clubbing both. This is the disadvantage of this one. Then a BS3 can also have a loop phenotype, whereas a DCT phenotype, which is not a combined phenotype, but a switch phenotype, is described in a Bartter syndrome type 3, in which initially you may have a loop and later you may switch over to the DCT phenotype. So this makes it confusing to classify all people as a loop, as a physiology-based classification. And similarly, there is a school of thought that how can you equate Bartter syndrome type 3 with Gitelman syndrome, because both of them would get classified into a physiology-based classification. So the age, proteinuria, and the growth patterns are different in Bartter syndrome type 3 and Gitelman syndrome. So what I mean to say is, although there are plus points in the physiology-based classification, it is not full of demerits also. So let us first see what is the approach to a child with hypokalemic metabolic alkalosis. So when you get a child with hypokalemic metabolic alkalosis, it's not always Bartter syndrome. We have an approach, and the approach would be based on the urinary chloride more than 20 or the urinary chloride less than 20. If you have less than 20, gastrointestinal causes and pulmonary causes will often predominate. This could include a congenital chloride diarrhea. This could include a ureterosigmoidostomy, persistent vomiting, infantile hypertrophic pyloric stenosis, etc. Or a hypercapnic syndrome also could be leading to a urinary chloride less than 20. Whereas when you have a urinary chloride more than 20, you have to see whether the blood pressure is normal or low. If it is low, it could be a Gitelman syndrome or a Bartter syndrome. If it is high, we would classify based on high aldosterone, high renin, or low aldosterone, low renin, or a high aldosterone, low renin. If you have a high renin and aldosterone, it could be renovascular hypertension or a renin secreting tumor. If it is a low aldosterone, low renin, it could be a Little syndrome, 11 beta hydroxysteroid dehydrogenase deficiency, or it could be a exogenous steroids or Cushing syndrome. When you have a high aldosterone, low renin, it could be a glucocorticoid remediable hypertension, for example. So with this, let us see a series of case scenarios, which we have seen in our experience. And hopefully this will help us understand the varied phenotypical spectrum of Bartter syndrome. So case 1 is a 8-month-old girl who was born to non-consanguineous parents. She's the second born. There was a poor weight gain since birth. She was weighing 2.46 kilos at birth, but now she weighs only 4.2 kilos at 8 months. Antenatally, there was no polyhydramnios. There was a term delivery at 37 weeks. History suggestive of polyuria was there. This was documented as 6 ml per kg per hour, and she was actually found to be dehydrated at admission with a low blood pressure. Sodium was found to be only 129, potassium 2.6, that is a hypokalemia. And she has a low serum chloride with high urinary chloride. The creatinine is normal. She has metabolic alkalosis as evidenced by the bicarbonate of 34. Serum phosphorus is normal. Calcium is 9.4 and magnesium is also 1.9. These are normal for age. So with this, following the algorithm of a child with hypokalemic metabolic alkalosis, a plasma renin activity was found to be high in the presence of a low blood pressure. So this child was worked up further, and when we did a next generation sequencing, she was found to have a homozygous pathogenic mutation in the CLCNKB gene, and this was actually a nonsense variation resulting in a stop codon and premature termination of the protein. So this proves Bartter syndrome type 3. This was actually a pathogenic mutation, and this child was started on potassium chloride supplements. She required a high dose, and indomethacin was also added at 1 milligram per kg per day. She has a satisfactory growth velocity. So this case is an example of a classical Bartter syndrome who presented at 8 months of age with failure to thrive and was found to be Bartter syndrome type 3. But every case is not as simple. So you have a case 2. This is a 2-year-old boy who presented with poor weight gain since birth. Again, at 2 years, he weighs only 7 kilos, whereas the birth weight was fairly okay. And he's born to 3rd-degree consanguineous parents, firstborn of his parents. There was no polyhydramnios. It was a preterm delivery at 36 weeks. The history was suggestive of polyuria and later documented to be polyuria. There was no dehydration. Now you see here, the serum sodium is found to be 146, which is hypernatremia actually. And the potassium was 3.8. The chloride was 98. So there was no hypokalemia, and he actually had a hypernatremia. The creatinine was normal. The bicarbonate was 22, normal. The phosphorus, calcium, and magnesium also normal. So at this juncture, because there was polyuria along with hypernatremia and the serum osmolality was very high, we suspected that it is actually a nephrogenic diabetes insipidus, and the urine osmolality was done, which was found to be very low. It was only 120, and a water deprivation test was done, which showed urine osmolality to be still low. And then a pitresin test was done, which showed no change in the urine osmolality. It remained within 110% of the baseline. So this suggested actually a nephrogenic diabetes insipidus, and we actually thought that it is an X-linked recessive form of nephrogenic diabetes insipidus because he was a boy. So treatment was done. He was started on thiazides for the nephrogenic DI, and there was improvement in the polyuria. It took about 2 months for the polyuria to subside, and we had counseled him to undergo a next generation sequencing to look for mutations in the genes coding the V2 receptor and the aquaporin 2 gene, which are actually responsible for a nephrogenic diabetes insipidus. But they were not able to do it at that particular point of time. And then he defaulted all the drugs for a year and was lost to follow-up. Subsequently, what we noticed is at the end of 1 year, when he returned, he had presented with a neck flop. At this juncture, the child who never had a hypokalemia and on the contrary had hypernatremia originally, this child was now found to have a hypokalemia with potassium of 2.1 only, and there was dehydration with polyuria. At this juncture, we found him to have metabolic alkalosis with bicarbonate levels being 31 milliequivalents per liter, and there was no hypertension. So we did a urinary chloride, which was high, and the serum chloride was low. We did a plasma renin activity high. So we also observed that he had some features of mild rickets at this point, and the ultrasound showed a nephrocalcinosis. The urinary calcium creatinine ratio was found to be high. So we revised the diagnosis to Bartter syndrome. And what we noticed was that the NGS showed a mutation in the gene coding the NKCC2, which is the SLC12A1 gene. And so the final diagnosis was revised to Bartter syndrome type 1, and he was started on potassium chloride and indomethacin. So this case is not a straightforward case. Who would think of Bartter syndrome in the presence of hypernatremia and absence of hypokalemia and absence of metabolic alkalosis originally? So this was because there was a severe hypokalemia originally, and that triggered a secondary nephrogenic diabetes insipidus. So this presentation is well reported. So hypokalemia actually blunts the AVPR2, which is the gene coding the V2 receptors, as well as the aquaporin 2 receptors. So the channels. So ultimately what you get is a nephrogenic diabetes insipidus. Bartter syndrome is well reported in the etiology of nephrogenic diabetes insipidus. So this case, the lesson that we learned, we actually published it in Indian Pediatrics. And the lesson that we learned is that Bartter syndrome can present with a nephrogenic DI as an atypical feature. The symptomatology may evolve later. So what are the other phenotypes? This is actually a Bartter syndrome type 1. And let us see the other features of Bartter syndrome 1 and 2 that are reported. Massive polyuria has been reported in literature sometimes to the extent of 20 ml per kg per hour. And although we say, like I said earlier, that there is a loop phenotype and there is a DCT phenotype. So Bartter syndrome type 1 and 2 would ideally be classified as a loop phenotype, not as a DCT. But you see in a particular series from Costa Rica, which is a Latin American country, you would find that hypomagnesemia was reported as much as about 50%. So these are the fallacies in the pathophysiological classification also. So there is a peculiar phase in type 1 and 2, which is considered a dystrophic premature baby. So you have a triangular face with prominent forehead and large eyes with protruding ears. Fever of unknown origin is reported due to diarrhea with vomiting and convulsions. These are attributable to high prostaglandin levels in the serum. Osteopenia with renal phosphate wasting is reported in type 1 and 2. And in our case, indeed, we had features of some rickets at the second admission. The mechanisms are not fully clear. It is thought that hyperprostaglandinemia might be contributing to renal phosphorus wasting by blunting the NPT2A channels. And similarly, high PTH also might be contributing to renal phosphorus wasting. Now, very rarely you see type 1 and type 2 Bartter have been reported as late as 13 and 15 years with very mild symptoms. These are all atypical features, and nephrogenic DI has been reported earlier. The renal function in type 1 and type 2 is generally well preserved, but ESRD has been rarely reported. Indomethacin treatment has been shown to reduce the hypercalciuria. And Bartter syndrome type 2 can initially cause a hyperkalemia, so it can mimic a pseudo hypoaldosteronism type 1. So later on also the big potassium channels get activated and they push the potassium into the urine. But even then, hypokalemia is the least in Bartter syndrome type 2 as compared to the other types of Bartter. Type 2 is the ROMK. Now we come to case 3. This is a 6-year-old boy who was referred to us as Bartter syndrome. Why? Because he had hypokalemic metabolic alkalosis from another hospital. He was found to have polyuria. He was found to have rickets. Now, rickets is reported in Bartter, but it's not a very common feature. It's an atypical feature. It's not seen in all of them, but it is reported, but it's not so common. So there was bony deformity in this child in the lower limbs. He had failure to thrive. His bicarbonate level was 33. His phosphorus level was only 1.1. So it was a severe hypophosphatemia. The calcium levels were normal. And serum potassium was found to be very low, 2.8. He had a hypercalciuria, medullary nephrocalcinosis. So what should be done next? This didn't look to us like Bartter because there was a severe rickets. So we thought we'll investigate him further. So we did a FePO4, which was found to be 85%, and the TMP-GFR was only 1.4, suggesting a phosphaturia. The eGFR was normal for age. At this point, we decided to do a 24-hour urinary protein. So this was found to be 3.1 grams in 24 hours, which is a nephrotic range proteinuria. And the urine albumin by dipstick was only 2+. So what does this suggest? This is not Bartter. So this child had a nephrotic range proteinuria, and albuminuria is not correlating by dipstick with this, suggesting excretion of some other proteins. So we thought of a dent disease type 1, and a urine beta-2 microglobulin was found to be extremely high. And then a clinical exome sequencing was done, which actually showed a dent disease type 1. It was a hemizygous X-linked recessive pathogenic mutation in the CLCN5 channel. He was ultimately treated with neutral phosphate supplements and thiazides for the hypercalciuria. So this is actually a pseudo Bartter. So beware, every hypokalemic metabolic alkalosis is not Bartter. Even if the blood pressure is low, there are many pseudo Bartter kind of conditions. And here what has actually happened is there was a so severe polyuria that it led to a secondary hyperaldosteronism mimicking a Bartter kind of picture. So there are many kinds of pseudo Bartter reported among tubular disorders. These include cystinosis, dent disease type 1 and dent disease type 2. All have been shown to have a pseudo Bartter kind of picture in many cases. Even in adults, you would see Sjogren syndrome, mitochondrial disorders, and loop diuretic or laxative abuse also mimicking a Bartter kind of picture. This case which we had was notable for refractory rickets, and this we actually published in pediatric nephrology. So another important disease that one should be aware of is cystic fibrosis. Cystic fibrosis may mimic Bartter. If you do not have any lung manifestations, sometimes the distinction may be very difficult. And in our own experience, among about 20 cases of Bartter in whom we have sent mutations, 2 of them actually turned out to be cystic fibrosis. So one should be aware that cystic fibrosis also, when there are no lung manifestations, it may be sometimes difficult to make a diagnosis. It may also have hypokalemic metabolic alkalosis. And this is one very good review published in the Indian Journal of Pediatrics, where cystic fibrosis in a very large series has been shown to mimic a Bartter syndrome. Now I go to the next case. This is actually a 1.5-year-old boy who presented with failure to thrive and polyuria. He had history of polyhydramnios in the neonatal period. He was a preterm born at 36 weeks, some dehydration, normal blood pressure, and sodium was low, 131, potassium was low, 2.8, chloride was also low, 92. The urinary chloride was found to be high. The creatinine was normal, bicarbonate high, and the calcium creatinine ratio suggested a hypercalciuria. He showed a plasma renin high. The ultrasound showed medullary nephrocalcinosis. So he was 1 to 3rd degree consanguineous parents, and this actually showed a Bartter syndrome type 2, which is due to a pathogenic mutation, a homozygous pathogenic mutation in the gene coding the ROMK, which is the KCJN1. And he was treated with indomethacin and potassium chloride. So in this case, we did not get evidence of hyperkalemia in the neonatal period. It might have been there. We could not document it. Information was not available. So this is an example of Bartter syndrome type 2 presenting with medullary nephrocalcinosis and failure to thrive. My next case is actually 11-month-old infant presenting with failure to thrive, no polyhydramnios. There was a past history of hypernatremia again with nephrogenic DI. She also had recurrent dehydration and later developed a hypokalemic metabolic alkalosis. By this time, we realized she is actually a Bartter. Plasma renin activity was found to be high. She had no hypercalciuria or nephrocalcinosis. Hearing assessment was normal. When a next generation sequencing was done, what we found was that there was not much of, they could not be very certain about what it is, but what the information that we got was that it appears to be a large deletion and therefore it has not been picked up on the NGS. Ultimately, we did an MLPA and the MLPA suggested a homozygous deletion. So a large deletion in Bartter, this is actually a type 3 Bartter, and this was actually, she has gone into CKD 3B now, and we have withheld the indomethacin because of the low GFR. the recurrent AKI or the hypokalemic tubulopathy or possibly a very large deletion could have accounted for the low EGFR in this particular case. Now my next case is this is the second last case. It's a 1-year-old boy with severe failure to thrive, polyhydramnios, prematurity, and severe polyuria, hypokalemia, metabolic alkalosis, hyponatremia, no hypercalciuria or nephrocalcinosis. Serum magnesium has been found to be low in this child, only 1.1. The blood pressure was very low. Actually, he was in shock originally. And the urinary chloride was found to be high with serum chloride low. Since there was polyhydramnios, we were expecting actually a type 1 or a type 2, but actually it has come out to be a CLCNKB, which is a type 3 mutation. So the lesson learned from this case is that type 3 has a very wide phenotypical variability, and it too can manifest with polyhydramnios to the extent of about 25% in some series. So as I said earlier, type 3 is the most variable and the most confusing variety of Bartter. So it may have an antenatal onset, it may have a classical onset. We generally tend to view class 3 as only classical, but it can be having an antenatal onset. So the type 3 is so variable that these kinds of atypical presentations have been reported. This can range from an antenatal Bartter to a Gentleman kind of phenotype. There is no deafness in type 3 because the CLCNKA Barton complex is actually intact. And nephrogenic DI is reported in this also. This variety has the lowest chloride among all the Barters because it involves the chloride channel. Isostenuria is there in this as compared to hypostenuria in type 1 and type 2. Failure to thrive is common in this also like the other types. Osteopenia is reported here also. Hypophosphatemia is reported due to hypokalemic tubulopathy. But what is actually important here is that only 20% of them have nephrocalcinosis as opposed to a very large number in type 1 and type 2. Half of them can have hypomagnesemia here, which could be a DCT phenotype kind of thing. Inter-sibling heterogeneity is reported. Racial heterogeneity is reported. For example, in literature, the African Americans are shown to have a more severe phenotype. A defect in platelet aggregation has been reported, but it's very rare. And Bartter syndrome type 3 has also been sometimes shown to develop FSGS, even nephropathy, etc., with severe proteinuria. Renal failure also may occur, and multiple reasons have been suggested. My last case is a 10-month-old boy who presented with failure to thrive and polyuria, no polyhydramnios, term baby weighing 2.6. So he has failure to thrive, hypokalemic, metabolic alkalosis with hypochloremia and hypomagnesemia. So what would you think? So we thought this is possibly a Bartter, but we have got actually a Gentleman. So it's a 10-month-old child. Only a handful of reports of infantile Gentleman exist in literature. Mostly Gentleman is at a much later age. So sometimes you can be wrong. You see, when the urinary calcium creatinine ratio is high, you can rule out Gentleman. But when it is normal or low, you cannot rule out. So here you have a Gentleman, and it was actually a compound heterozygous mutation in the SLC12A3 gene. And segregation analysis also has been done, and we have found that the parents are carriers. So management of Bartter syndrome is through indomethacin. Dose is about 1 to 2.5 milligrams per kg per day. One should be cautious while using higher doses because they are nephrotoxic. And GI complications, ulcers, necrotizing enterocolitis, and AKI are reported with indomethacin. So one must be careful, especially because you are polyuric, and while having polyuria, if you give an NSAID, the nephrotoxicity might be enhanced. KCL is required. It's often difficult to correct a Bartter's hypokalemia. Spironolactone can be added, but there are concerns that on one hand, you have a hyponatremia and you are blocking aldosterone. So it may lead to more hyponatremia. So it is a controversial thing. AC inhibitors are also controversial because if you use them with indomethacin, it can cause hypotension and AKI. If there is hypomagnesemia, magnesium supplements will be required, but typically the hypomagnesemia is difficult to treat. Treatment improves the growth, but catch-up growth is often inadequate. Thiazide should not be added to treat hypercalciuria in Bartter. Indomethacin itself has been shown to reduce the hypercalciuria. And if you use thiazides, you may get more hypokalemia, you may get more hypomagnesemia, and you may worsen the dehydration. Rofecoxib, which is a selective COX-2 inhibitor, has been used. There are some trials, but it has a lot of cardiovascular effects and AKI. Salt supplementation may be needed in these children, and initially they may present with shock. Gene therapies are coming up, and vasopressin also is being investigated. One word about the major 2 mutations, the Bartter syndrome type 5. This is called the transient antenatal Bartter. It's a severe but transnatal antenatal form. It's a transient form. It's X-linked recessive in nature, so it tends to affect males more. There is severe polyhydramnios, and one particular French cohort, it accounted for 9% of all the antenatal Barters. Mutations in this gene actually reduce the expression of the NKCC2 in the TAL as well as the DCT. So why this major 2 mutation, actually you outgrow it, is because it is expressed in the hypoxic renal medulla in utero. And after birth, when the oxygenation improves, there is reduced dependence on the major 2. Serum chloride has been found to be highest in major 2 than other types of Bartter. You would recall that I had mentioned that serum chloride is lowest in Bartter syndrome type 3. And there is spontaneous resolution of polyuria in major syndrome type 2. This is the French series where in about 9% antenatal Bartter, this was found. So what are the outcomes of Bartter syndrome? There is one Italian registry by Puricelli et al. In which a long-term follow-up of 15 children with either a compound heterozygous or a homozygous mutation in type 1 or type 2 Bartter coding genes. This reported satisfactory growth after a median follow-up of about 10 years. The EGFR was less than 90 in only 1/4 of the patients. And this was patiently associated with overt proteinuria after follow-up of 10 years. Whereas another Italian registry in a cohort of 14 patients, they reported that 4 of them, these were type 3 Bartter as opposed to the other Italian registry, which was type 1 and type 2. So here they reported that the EGFR was less than 75 at a 14-year median follow-up. So one has to follow up these children carefully. So in this series showed that the height velocity remains low in type 3 Bartter. The height never catches up fully. The weight gain was found to be satisfactory. So my take-home messages are: every child with hypokalemic metabolic alkalosis should be approached systematically. Bartter syndrome and Gentleman syndrome are important renal tubular causes of hypokalemic metabolic alkalosis, and one should suspect them when the blood pressure is normal or low. The traditional gene-based classification of Bartter syndrome, as well as the proposed physiology-based classification of Bartter, have their own pros and cons. The physiology-based is not without any disadvantages. It also has problems. Bartter syndrome type 3 is the most, it has the widest range of phenotypical variability, starting from classical to even an antenatal onset. Type 1 and type 2 have typically antenatal onset with hypercalciuria. Type 4 is the one where you have sensorineural deafness. It's also an antenatal Bartter. Type 5 is due to major 2 mutations, and it can cause a transient Bartter syndrome. As of now, Bartter syndrome and Gentleman syndrome treatment is purely symptomatic based on potassium supplementation, salt supplementation, indomethacin. But vasopressin and gene therapy are under research. Thank you.
Dr. Kanav,
So
your
one
voice is breaking. Your voice is breaking, Dr. Kanav. Dr. Kanav Anand, you're there? Dr. Amrish, would you like to introduce Dr. Rajiv Sinha, or shall I go ahead?
Yes, I can introduce. Thank you, Dr. Sriram, for an excellent talk. This was very comprehensive, and this was, the case series was excellent. We all learned a lot from it. We will definitely take the questions after the next lecture. And the next lecture is by Dr. Rajiv Sinha. He is professor of pediatrics, and he is also the head of the department. Sorry about that. Can you hear me?
Yeah, you're audible.
Yep. So Dr. Rajiv Sinha is the professor of pediatrics and head of the Department of Pediatric Nephrology, Institute of Child Health, Kolkata. And he's a consultant pediatric nephrologist in Kolkata. He is recipient of multiple travel grants from ISN, IPNA, and he's also part of the International Society of Nephrology Educational Ambassador. He has contributed to multiple book chapters, and they have been published in IP textbook of pediatrics. He has also been, a mentor for publications in the International Pediatric Transplant Association. We are really proud to have you here, Dr. Sinha. We are looking forward to your talk.
Thank you very much. Let's see. I'm always apprehensive of field study. Is it okay?
Oh, it's not in slide share.
I'll do what I did last time. Now?
Yes.
Okay. So that makes me more relaxed. So I hope I'm audible, and I would like to start with thanking Dr. Kalaivani and the entire pediatric nephrology team of Mehta Children's Hospital for giving me this opportunity, and congratulate Dr. Kalaivani for continuing her effort of educating us over online. I'd also like to remark on that wonderful lecture by Dr. Srinivasan, and it was very extensive. My lecture hopefully will be more basic, and we will be trying to sort of have a whirlwind tour of how to suspect and evaluate a child with tubulopathy. So the objective will be primarily to look at the pattern, identify the pattern, because as most of us know that already, and I'm sure we will be reinforcing this throughout the next half an hour, 40 minutes, that what is important in the tubulopathy or tubular disorder is for us to be able to distinguish between the zebras, the giraffe, the cheetahs, the lion. So we have to be able to identify the pattern, the script. I'll not go through the renal physiology at all because it has been covered in previous sessions. But one thing I'm sure I'd like to re-emphasize again that although we focus more on the glomerulus and often we forget about tubules, but it is because of the tubules that we have sort of migrated from the sea to the land. There is sort of this of classifications of are there for tubular disorders, and I I love this one is this bar visible there? Cleverly? Hello? Hello, can you hear me?
Yeah. I'm able
Yeah, we
to
can hear you. Yeah.
Yeah, is this bar visible? I want, is a bar visible there, or you can like I've got
I'm
a
able
bar.
to, Dr. Rajiv, I'm able to see few things actually like wandering in your slide. We are not able to actually look at your slides clearly.
So how do I, is there this bar with the mute? How do I minimize it?
हाँ? लेने नहीं गया चाबी मेरे पास है छठी फ्लोर पे करो
Anyway, I don't know. So I will continue of whatever is possible here. So this is the mode of.
Stay a little away from the mic because your voice is also echoing.
Yeah.
Yeah.
So this is the classification which I like, because it is quite simple, and you can classify the tubular disorder in proximal. Proximal can be selective, for example, cystinuria, where you are losing only the cystine, or it can be the Fanconi syndrome. Various causes of Fanconi syndrome like cystinosis, Dale, Lois, etc., where, as we all know, and we will discuss it later on also, that we lose almost everything to the people. Then moving on, we have got the disorders of the distal nephron, which can be either salt wasting, which a couple of them has already been discussed by the previous speaker, Bartter and Gittelman, and pH1, pseudo hyperaldosteronism is another of the salt wasting. You can have the salt retaining variety, the Liddle syndrome. Then you have got the magnesium reabsorption disorders, the familial hypermagnesemia with hypercalciuria is an example of that, and then the disorder of the water reabsorption. Now, I'm sure all of you will agree that this is the most important slide for the next 30-35 minutes. That is the when you suspect renal tubular disorder. So clinically, if a child is presenting to you with a failure to strive, growth retardation, polyuria, polydipsia, refractory rickets, renal calculi, particularly with a family history, nephrocalcinosis, unexplained hypertension, significant hypertension, but you are not finding a cause, and child is young, like less than 6 years, 5 years, then you should start thinking of renal tubular disorder. Lab pictures, there are a certain lab pictures which are quite characteristic of an underlying renal tubulopathy. For example, hyperchloremic metabolic acidosis, metabolic alkalosis, hyponatremia, like low sodium, high potassium, and then hypercalciuria with normal serum calcium. So all of this, if you're encountering, then you should be starting to think whether you are dealing with a child with tubulopathy. So with that sort of a background, we will now dedicate the next session on trying to do some work by going to various case scenarios. And through this, we will hopefully be able to identify certain patterns. So our first child is was from Bangladesh. She is a 3-year-old girl who presented to us with failure to strive, polyuric and polydipsic. And I'm not exaggerating. The mother did say that she was so polydipsic that if you don't stop her, she will drink her own urine. So these were the initial investigations, and I have highlighted some of the abnormal one with rate. So we have got hypophosphatemia, we have got raised alkaline phosphatase, and an X-ray consistent with rickets, which we were suspecting anyway when we saw the picture. you can see the board leg. But the pattern which is primarily coming up from here is the normal anion gap metabolic acidosis with hypokalemia. So acidosis anion gap is 14.5, which is within the normal range. So it is a pattern of a normal anion gap metabolic acidosis with hypokalemia. We will come back to this child later on. Moving on to our next scenario is a child, 1.5-year-old boy. He was in fact a son of a pediatrician, and they came to us with a history of a failure to thrive, polyuria, constipated. Ultrasound was done for abdominal pain and for the bilateral nephrocalcinosis, and then was referred here. And here the pattern is almost like the previous one. Again, we are having a normal anion gap metabolic acidosis with hypokalemia. We will now move to our third case scenario. 11-month-old girl with a birth weight of 2.6 kilo and a current weight of 3.9 kilo. So again, failure to thrive. Did have 3 episodes of respiratory tract infection, including one needing ventilation. And this was the initial biochemistry. And what you can see here is again, the anion gap is normal, but in contrast to the previous child, this child has a hyperkalemia. So slightly different. First two child, normal anion gap metabolic acidosis with hypokalemia. This one was a normal anion gap metabolic acidosis with hyperkalemia. And similarly, here also a 4-month-old girl presenting with vomiting and lethargic. Again, failure to thrive, and again the same pattern of a normal anion gap metabolic acidosis with hyperkalemia. And also the one thing I'm sure you have all noticed is the low sodium. So in contrast to the previous children, last two, both of them have a low sodium, high potassium, and have got a normal anion gap metabolic acidosis. So I've been talking a lot about anion gap. A very brief introduction to the anion gap. We all know it is sodium plus potassium minus chloride plus bicarbonate. Some places don't use the potassium. So if you are using all these four, the sodium plus potassium minus chloride plus bicarbonate, then your upper reference is 18. And if you are not using that, then your upper reference is 14. So without potassium, the upper reference for the anion gap is 14. The other important thing is that you should remember that if your albumin is very much deranged, then your anion gap has to be adjusted, and this is the formula for adjusting for albumin. And below you can find a formula for adjusting for the lactate also. Because nowadays it is advised that since most of these blood gas analyzer is giving lactate, it is better to adjust your anion gap for both lactate and albumin. And we know that we have got a high anion gap metabolic acidosis, which we nephrologists don't deal with that much, but we do remember the MUT5, the methanol, uremia, decay, paraldehyde, iron, lactate poisoning, all those things. And then we have got the normal anion gap metabolic acidosis or the hyperchloremic metabolic acidosis, which is the one which we will be discussing more today. So a very simple and as I said before, I do like simple things and a very simplistic approach to normal anion gap metabolic acidosis, also called as the hyperchloremic metabolic acidosis. So the first thing to be done, I hope we can see my arrow pointer. The first thing to be done is to look at the urine net gap. This is also often said as urine anion gap, but ideally you should be calling it as the urine net gap, net ion gap. Now, if that is negative, that usually means is that you are unlikely to be dealing with a renal tubular. It can be something else is the cause for the urine for the normal anion gap metabolic acidosis. Something else like a loss of bicarbonate from an extrarenal source, and the commonest is the diarrhea. If that is positive, so if the urine anion gap is positive, then it means that it is more likely to be a renal tubular acidosis. And then by looking at the potassium and the urine pH, most of the time you can come up with a diagnosis of either it is a type 1 RTA that is distal, or type 2 RTA proximal, or it is a type 4 RTA. So as you can see here, that most of the time you don't really require the more complicated investigations like a fractional expression of bicarbonate or this UV, PCO2, etc. And you can come up with a tentative diagnosis. So that was mentioned. I did discuss about urine anion, about the serum anion gap. Now about the urine anion gap, which I just said was should not be mentioning it as a urine anion gap. The better word is urine net charge. And if it is positive, so if the sodium plus potassium is greater than chloride in presence of acidosis, it means that your kidney is not doing its work. The distal acidification is impaired. On the other hand, if your distal acidification is not impaired, if the kidney is working fine, then your sodium plus potassium should be less than chloride, as is shown here. And again, from this urine, with the help of the urine anion net charge, as well as with this measured and actual measured and calculated urine osmolality, you can calculate the ammonium that is present in the urine. And if the calculated ammonium is less than 20, it also further the corroborates that your distal acidification mechanism or your ammonium excretion mechanism is defective. So in this particular slide, we are looking at two important concepts. One is the urine net charge, and the other is the urine osmolar gap, which can often be useful for where they are confusion. Like if we are not very sure whether we are dealing with a renal tubular acidosis, proximal, distal, this sometimes can help in confirming yes, we are dealing with the renal tubular acidosis. Few words on the urine pH also. The most important thing is that ideally it should be checked by a glass electrode, by a pH meter, as is shown here. So it should be checked by a urine pH meter, and it should be checked on the bedside. Rarely we do have to do something called a fusamide acidification test, but most of the time you don't really require fusamide acidification. You can straight away go for your urine pH, and if your urine pH is below 5.5 in presence of acidosis, then you are more or less sure that you are dealing with proximal artery. If you have to go for a fusamide acidification test, then there is this protocol here, and this actually works on the principle that after you are sure that the child is acidotic, you give a fusamide IV or oral, and what fusamide does is that it upregulates the distal sodium reabsorption, making the environment of the distal tubule ideal for acidification. And after giving fusamide, If your urine pH fails to fall below 5.5, it is distal. If it falls below 5.5, it is proximal. And an example of a systematic chemistry that we did recently in one of our babies is so we now go back to our those cases. And what we have realized is that in all these three or four cases, like case one, case two, and then the 3SCB, we are dealing with a normal anion gap metabolic acidosis. One hypokalemic, the first two hypokalemic, the last is hyperkalemic, and what we need further is some urine biochemistry and the urine pH. So that's what was done. For our first child from Bangladesh, the urine anion gap or the urine net charge was positive. The urine pH was 5.1. So it went down below 5.5. The urine sugar was positive. Child was losing lot of phosphate, as you can see from the tubular reabsorption of phosphate or TMP-GFR. And hence we are already having the diagnosis of most probably this child is having Fanconi syndrome, and we all know that Fanconi syndrome is usually from can result from a number of wide variety of disorders ranging from say galactosemia, thalassemia, cystinosis, Fanconi Bickel, all of this can present as Fanconi syndrome. And of this, cystinosis is supposed to be the most common cause of Fanconi syndrome in pediatric age too. So we went on to look into the eyes, where we could see cystin crystals in the cornea, and we had a diagnosis of Fanconi. Was started on cystiamine, and then subsequently this was also confirmed by genetics. What about our second child, the doctor's child? Here we see that the urine anion gap was again positive, so it is renal tubular acidosis. We did calculate the hidden urine ammonium, which cannot be measured usually. So as you remember, we said that we can calculate it with the help of urinary osmolar gas, which was 12. And if you remember that in acidosis, if your kidney is working fine, then your urinary ammonium has to increase, and ideally it will be more than 20. So it also confirms that there is some defect in the urinary ammonium generation. Urinary pH did not go below 5.5. The minimum it went was 6.1. The child also had a hypercalciuria, and we are already with agreeing. We already have a tentative diagnosis in our mind, I'm sure, of a distal renal tubular acidosis. Well, the child was started on bicarbonate as well as phosphate, particularly the phosphate, and there was a remarkable growth. Distal RCA is a very good disease to treat most of the time, because you can have a remarkable growth just with the use of bicarbonate supplement, and we usually give it in the form of phosphate because it will supply both bicarbonate as well as potassium. And we had a genetic confirmation by ATP6B0A4 mutation, which can also cause sensorineural hearing loss, and but this child did not have it, but is on a regular or genetic follow-up. So distal RCA, unlike the proximal RCA, most of them are from various causes like cystinosis, Wilson, thalassemia, etc. Distal RCA more commonly are from various mutations. Here you can find, you can see some of the variants which have been associated with distal RCA. Some of them are associated with deafness, and the one SLC4A1 has been associated with RBC wall defect, spherocytosis. And in fact, we reported one such family from India way back in 2013. But also remember, and we will discuss it later on also, that distal RCA can also have have non-primary genetic forms, like it can be from autoimmune disease. In fact, very recently we diagnosed a child with distal RTA who have Sjogren's, and then it can be from other diseases like other SLE manifestations, primary hyperparathyroidism, Wilson disease, and so on. So we have sorted our first two child. Now moving on to the last two, the 3A and 3B. Both of them, if you remember, had a failure to strive with normal anion gap metabolism and hyperkalemia. In contrast to the previous two children who were hypokalemic, now we are moving to the hyperkalemic. And again, the urine anion gap here also was high. So in this, we are dealing with then renal tubular acidosis, but remember that the potassium is on the higher side. We then went on to do a urine osmolality and a serum osmolality in both of these children. And with the help of that, we were able to calculate something called TTKG, transtubular potassium gradient. It will be described in later, but it was both low. So we are having now a child with normal anion gap metabolism with hyperkalemia and a very low TTKG. Now, what is TTKG? TTKG is the measure of the driving force of potassium secretion in the cortical collecting duct. And for its interpretation, you need to have 2 or 3 assumptions. One is that your antidiuretic hormone needs to be working. Second is that your urinary sodium should be more than 20. Now, if this is being failed, if this is being sick, then if in the presence of hyperkalemia, if your TTKG is less than 7, it suggests that your kidney is not discarding your potassium. I repeat, in presence of hyperkalemia, if your TTKG is less than 7, it means that your kidney is not discarding your potassium. Because in hyperkalemia, what you are expecting? You are expecting that the kidney will be discarding. It is taking out all the potassium. But if the TTKG is less than 7, then it is not happening. And if you remember that in our cell, the TTKG was 1.25 and 1.7. So definitely there is some problem with the in the kidney where it is not been able to discard the potassium. And the other caveat, also has to be fulfilled is that the child stationing clearance has to be more than say 15 or 20. Usually, an inappropriate TTKG here means that either it is a mineralocorticoid deficiency or deficiency. That is, either the aldosterone is not there, or if the aldosterone is there, but it is not being able to work on the aldosterone receptors, or there is some problem with the ENA. Okay, so this is what is meant by in this scenario where you have got a hyperkalemia and your TTKG is less than 7, and various disorders can cause this. Aldosterone deficiency, obviously the one that comes in mind is the Addison's disease and the congenital adrenal hyperplasia, but also we have got conditions like a hyporenemic hypoaldosteronism in with chronic nephropathy. We see it with SLE, adults see them with diabetic nephropathy also. Also, hyporenemic hypoaldosteronism, it can be a presentation with acute glomerulonephritis. And for the mineralocorticoid resistance, the commonest is the hypoaldosteronism type 1, which comes into your mind first. Why? there is the aldosterone is there, but the receptor problem. So that is the primary hyperaldosteronism type 1. But more common are things like obstructive uropathy, medullary cystic disease, interstitial nephritis. All of these where there is a trans receptor deficit of potential deficit, and there also the same thing happens is that the despite the presence of aldosterone, it fails to work, and it is unable to bring in the sodium and push out the potassium, and that results into the characteristic hallmark of a low sodium hypotension. So in our two child, what we did was we looked at the aldosterone. In the first child, the aldosterone was sky high, and we have a diagnosis of pH 1. In the second one, the aldosterone was not that elevated, and uh, further investigation proved it to be a case of congenital adrenal hyperplasia. So first child was PHL1, which is because of the INAC mutation, where the aldosterone is there, but it is unable to work on the receptor. And the second one is congenital adrenal hyperplasia. Now, this is a brief summary of how you differentiate between proximal, distal, and type 4 RTA. And as I said before, one of the most important things is the urine pH and the plasma potassium. Urine anion gap and basically proves that your child is having RTA, and then with the combination of plasma potassium and urine pH, most of the time you are able to stand whether it is proximal, distal, or type. Sometimes you do require more sophisticated tests like a UV PCO2 or fractional excretion of bicarbonate, but most of the time those are of academic use. Now there are suggestions coming up that instead of classifying as type 1 RTA, type 2 RTA, and type 4 RTA, it is better you just classify based on the defect. So a defect in the hydrogen ion secretion in the proximal tubule, or defect in ammonium ion excretion, and then again this defect in the ammonium ion excretion can be either because of defect in the ammonia or defect in the hydrogen ion secretion in the distal nephron. But so this is an interesting concept that is coming up, which is quite anathema of what we have been learning. That maybe rather than saying say type 1, type 2 RTA, better just to classify it as as what underlying defect is, and that will be also useful in management. Now we now change gear, and we move on to another case of a 5-year-old boy with a celiac tooth stripe, presenting with sudden onset of generalized body weakness and respiratory difficulty, needed intubation and ventilation, but then showed a remarkable improvement within a couple of hours of starting maintenance fluids. Now this happened 2-3 times in his life over say a year or two, and then the physician thought that no, this child needs further evaluation. And this was the initial evaluation with initial biochemistry when the child is evaluated. And what we see here is hypokalemia with a metabolic alkalosis and a low chloride. So previously it was just the reverse. It was hypokalemia with normal anion gap metabolic acidosis, that is hyperchloremic metabolic acidosis, and here we are seeing hypokalemia with metabolic alkalosis and low chloride. So a pattern is here: alkalosis with hypokalemia and hypochloremia. For the evaluation of the urine shows that the child is losing everything, including potassium, chloride, and calcium, and we are already having the diagnosis, as it was previously explained by our previous speaker, the Bartter syndrome. I'll skip the slide on the Bartter because it has been quite elegantly explained by Srinivasan. But and our particular child was having a KCNJ1. Speaking on Bartter, you have to say something on Dickelman. Same pattern of alkalosis with hypokalemia and hypochloremia, but gentlemen usually have hypomagnesemia and hypocalcemia. So, although as was just mentioned that you can have lot of overlap between Bartter and gentlemen, but then at least in for the and postgraduate teaching, at least till MD, I think we can say that that if you are having a hypokalemic alkalosis and your magnesium is low and you are having hypocalciuria, it most probably you should be thinking of GP. Gipelment is because of the mutation in the sodium chloride channel. Moving on to our another case of a 2-year-old boy with a failure to thrive, and he presented with hypertension. And so, same pattern: metabolic alkalosis, hypokalemia, but hypertension. Further evaluation showed that has a very low plasma renin activity, a low aldosterone, and a normal urinary stress profile. Did not respond to spironolactone, but responded to amiloride. And I'm sure most of you already have the diagnosis after this statement. That did not respond to spironolactone, but responded to amiloride, means that the cell is having some inact mutation and is having little symptoms. So we said that the inactivating mutation of inact, we get we discussed before PHA1, and if it is an activating mutation, then we get Liddle syndrome. Similarly, we have to mention a bit about the Gordon syndrome, which is the activating mutation of sodium chloride. In activating mutation, we get Gitelman. Activating mutation, we get Gordon syndrome, when there is a hypertension with hyperkalemia. So this is one of those rare conditions where we have got hypertension with hyperkalemia. Again, the did mention about the approach to a child with metabolic alkalosis, and it depends on urinary chloride. If your urinary chloride is low, then you are thinking of cystic fibrosis, vomiting, ANG drainage. All of those are the cause of the metabolic alkalosis and hypokalemia. If the urinary chloride is high, then it is most probably renal. If the blood pressure is high, then you are you look at the aldosterone. If the aldosterone is high, the hyperaldosteronism, the aldosterone is normal, and your renin is low, then it is Liddle or the AME, etc. On the other hand, if your blood pressure is normal or low, you are dealing with Bartter syndrome or DP. Next, we have got a 4 case snippet. First one, a child presenting with recurrent dysuria, sterile pyuria, negative for TB, ultrasound done for nephrocalcinosis, calcium was normal, phosphate was normal, bicarbonate was normal, creatinine slightly high, a 24-hour urine calcium was high, 24-hour urine magnesium was high, and 24-hour urine citrate was low. So here the first main thing seems to be the high calcium, the high magnesium, and sorry, one of the most important things which I forgot to type here was that this cell had a low magnesium of 1.2. Sorry, I forgot to mention in the first one. Next one is a child which came with a generalized tonic-clonic convulsion, found to have a low calcium, low magnesium, Creatinine was on the higher side, PTH was 28.1, and urine magnesium on the higher side, and the kidney ultrasound saying bilateral cystic kidney disease. So PTH 28.1 is not appropriate. If you're having a low calcium, your PTH should be further high. So most probably this low PTH reflects maybe a persistently low magnesium, which has depressed the PTH. Case 60 was a 1 year 2 month old boy coming with recurrent convulsions from 1.5 months of age. Has been shown to have a persistently low calcium and magnesium, and again a very low PTH. But unlike the earlier two child, we could not document any loss of urinary or fecal magnesium. So the previous two, if you remember, was having a loss of magnesium to the urine. Here, there was no loss of magnesium in the urine, and there was no diarrhea. And last one is a 3-month-old boy admitted with dehydration, found to have deep polyuric and polypeptide. And here we have a high calcium and a borderline magnesium. And the calcium creatinine ratio is quite low, 0.01. So various magnesium disorders, and we can add in. I'll not go into them in detail, but I'm sure you can identify some of our cases there. First one, and I'm really sorry I did mention this before. I didn't type it. This child had a low magnesium. So this child basically, again repeating, presenting with dysuria, found out to have hypercalciuria, also high magnesium in the urine, low serum magnesium, low calcium, and the high creatinine. Mutation confirmed it to be a hypercalciuric, hypomagnesiemic here from the clotting system. Next one, with the bilateral cyst and low magnesium, turned out to have a HNF1 beta mutation, and HNF1 beta mutation has been shown to cause magnesium to renal magnesium deficiency. Third child, the one who was having convulsions from about 1.5 months of age, was found to have a compound heterozygous mutation in TRPM6. TRPM6 is a sort of a gatekeeper of magnesium in the intestine. So because this was mutated, the child was unable to absorb magnesium from the intestine, and because the magnesium in the body was low, that resulted into the low PTH and low calcium. And the last child mutation was found to have hypocalciuric, hypercalcemic variety because of mutation. Moving on to another set, stone. This was an 8-year-old female with recurrent affliction with pyonephrosis. Had at least 3 surgeries for stone removal, but nobody had bothered to look at the urine RE properly, urine microscopy, which had distinct crystals, and the child had cystinuria. This was an interesting child which we encountered when I was in CMC Vellore. 11-month-old child with a sudden onset of anuria. There was a family history of a death in an earlier male sibling. And this anuria was because of bilateral urethric stone infection, resulting into what we define it as a reflex anuria. So the child had a bilateral stenting done, and further evaluation showed a significant proteinuria and a significant hypercalciuria. And I'm sure many of you are already having the diagnosis of because we are here now having hypercalciuria, significant proteinuria, and male child. So we were suspecting James disease, and it was proven to be that in the genetic mutation. James disease can be from a mutation for CLC5 or CL1, and this is usually this carrier or the channel protein linked to the tubulin and the megalin. Very important slide emphasizing that almost 50% of childhood bone disease have an underlying cause, and that's why they should be thoroughly evaluated. Case scenario 8, this is a 11-month-old boy presented with convulsion and ultrasound showing a gross hydronephrosis. Now, biochemistry shows this high sodium of 166. So up till now, we haven't really dealt with high sodium. Most of the time, sodium has been normal, maybe slightly on the lower side. So there we are now having a high sodium, slightly high creatinine, and the urine RE showing a specific gravity of 1005. If you're having a sodium of 166, your urine should be concentrated. But here we are having a urine specific gravity of 1005, which is already telling you the diagnosis. So how do you approach a child with polyuria? Well, you first rule out renal tubular acidosis, chronic kidney disease, diabetes mellitus, and then you go for a paired sample of a urine and plasma osmolality. If your urine osmolality is more than 300, urine osmolality is less than 300, and your plasma osmolality is more than 300, then you can straight away go for vasopressin test. Otherwise, you might request to have a water deprivation test. In our child, the plasma osmolality was 320, urine osmolality was 110. So we were thinking of NDI. Water deprivation test was not required. We went for a vasopressin challenge test, and there was no response to vasopressin, and the child had a diagnosis of nephrogenic diabetes insipidus, which was further confirmed by the infection. Nephrogenic diabetes insipidus usually is caused by either mutation in the vasopressin receptor or in the aquaporin, and it can be X-linked or upstream recessive respectively. But then, as described by our previous speaker, you have to remember that sometimes nephrogenic diabetes insipidus can also be a result from other diseases. For example, post-obstructive diuresis, obstructive uropathy, sickle cell disease, CKD, hypercalcemia, and as was described in the previous slide, and you will see subsequently also, it can also be a manifestation of Bartter syndrome. So I just similar to Srinivas, we also had a child with a Bartter syndrome. So I'll just quickly go through this child presented to us in stock, and you can see that on initially the child was having normal anion-gap metabolic acidosis. But then if you had corrected it with albumin, it was on the high anion-gap metabolic acidosis. Child was having low sodium, low potassium, and we were thinking of whether it is a distal artery or not, or some form of artery. Subsequently, as the time progressed, the child went on to develop metabolic alkalosis. So from metabolic acidosis, child slowly went on to develop a metabolic alkalosis. Hypokalemia persisted, but then the sodium also went up. Throughout this, the child remained polyuric. So we were quite confused at this moment that what are we dealing with? Are we dealing with a Bartter syndrome? Why? No, because of a metabolic alkalosis and the hypokalemia, or are we dealing with now nephrogenic diabetes insipidus because of the hypernatremia? We did a dissociation challenge test to which the child did not respond. So this was more in line with NDI. But we also looked at the PRA. This was very high. So this was more in line with Bartter. What your mind doesn't know, your eye doesn't see. So at that, I have to admit that that was in 2013-14. I I specifically did not have much idea of a Barter which can present as NDI. So I contacted my guru, Dr. Detlef Bokenhoff, and he did a genetic mutation, uh, and it can turn out to be Barker. And in fact, what he said is that in Montreal, which is the sort of mecca for NDI, if you are not finding a mutation in the vasopressin or the aquaporin gene, then the next gene that they look for is the Barker gene KCNJ1 followed by the ASLC12A1. And both our child as well as the, the one described by President was having a mutation on SLC12A. Now that your eye knows, your mind knows, your eye also starts seeing quite a lot, and subsequently within a year or so, we diagnosed and published a couple of children with one with the distal RTA and one with the proximal RTA who presented with injury. Just a couple of children with, I'm sure you all have got the diagnosis of Loeys syndrome, and this one is with the hepatosplenomegaly, first stage hepatosplenomegaly, wicked time in Vickers syndrome. Early this year, we published our experience from Eastern India on the use of whole exome sequencing for in tubular practice. Total number of students was 77 with 55 pathogenic variants and 24 novel pathogenic or likely pathogenic variants. We had a very good output of the whole exome sequencing. The 70% cases we were able to come up with a diagnosis. But what was interesting was that whole exome sequencing helped us in revision of diagnosis in 18% of cases. And there was an impact on clinical management in 31%. So emphasizing the importance of genetics nowadays in tubular practice. And some of the interesting change of diagnosis included, as alluded by Srinivas, about like cystic fibrosis being thought as a Bartter syndrome, diagnosing very specifically tyrosinemia or cystinosis, and being able to give them these medication, offer some treatment specifically. Not to forget that tubular practice can be from other etiologies which are not primarily genetic. So we have published this case of Wilson disease, who presented with gross hematuria, who was referred to as with gross hematuria, found out to have hypercalciuria, and then the cause of the hypercalciuria was a dysplasia. And we already discussed before that Wilson can cause renal tubular acidosis. This is an interesting case, the second one, where this child with a known cause of thalassemia presented to us with AKI as well as all cases of proximal tubular practice. Child was on this oral iron chelation, and further studies including pharmacogenomics showed that this child had a certain variant which predisposed you to most side effects of the death period, and that was causing the problem here. Then this one was a child who presented with urinary frequency and hypertension, but the cause of this was again hypercalciuria, which was because of some hypervitaminosis B, which was because of sarcoidosis. And we have just submitted this as an interesting case report of acute leukemia presenting as Fanconi syndrome. There are various drugs which have been associated with Fanconi syndrome as well as Bartter, including gentamicin. So, in conclusion, these are the various lab tests which can be useful in finding out the pattern. Pattern for proximal tubule, that is low normal sodium, low potassium, low bicarbonate, low phosphate, using calcium phosphate protein. Pattern for in the ascending, some problem in the ascending limb, that is the fusamate pattern of normal sodium, low potassium, metabolic alkalosis, so high bicarbonate, magnesium low or normal, phosphate normal, urine potassium high, chloride not mentioned here, but chloride will be high, and then the pattern of a DCT, that is thiazide, with again low potassium, high bicarbonate. But how do we differentiate is that they have a low magnesium and a low calcium. And then in pattern of the collecting dust, that is a low sodium, high potassium, meaning that there's something with either aldosterone resistance or aldosterone deficiency, and the PTKG will help. I'd like to thank Dr. Bokenhoff, from whom I've taken this slide. And last word is that tubulopathy is a sort of a puzzle where you have to put in the missing pieces, and once you've done that, then you really have the prize for you, because many a times treating these children is quite rewarding, because unlike CKD etc., here you don't really have to stop various food etc. In fact, they are encouraged to often to have salt food, encouraged to have more water. So it is much more easier sometimes when compared to previous CKD. And particularly diseases like distal RTA, you can have, like, at least from my own personal experience, we have had excellent response. Thank you very much.
Thank you, Dr. Rajiv, for the lovely presentation. I hope things are been made very simple by the lovely algorithmic approach that you showed. So now let us take some questions. So first question I'd like to ask Dr. Sriram, like, what is the overall prognostication for a child with Bartter syndrome? Like, if a patient comes to you, the child has been diagnosed Bartter, the parents ask, what is my long-term prognosis? So what will you like to answer?
I think I already mentioned in the slides that there are two long-term studies. Both are Italian registries. Small number of children, about 15 or 14. They have been followed up for median times of 10 years, 14 years. So one of the registries found that in type 1 and type 2 Bartter, the overall EGFR continued to be low in about 25% of children at a median follow-up of 10 years. But the growth was satisfactory. The other group, this is published in AJKD in 2007. This showed about 14 children, and about 30% of them had a low EGFR less than 75 at about 14 years median follow-up. Height continued to remain low in these, but the weight was satisfactory. Overall, children will continue to do well if they are compliant with their potassium supplements, and they require a good follow-up to ascertain the compliance with medication and to monitor the toxicity of the drugs also.
Fine. There was another question that you already answered in the chat box. I'd like to ask you again, like, why is there no hypertension in Bartter syndrome in spite of high renin activity? Because this is one of the very favorite Viva questions asked to right from the UG days to the super specialty days.
That's because of the polyuria and the natriuresis prevent you from getting hypertension, even though you have a plasma renin activity that is high.
Fine. So question to Dr. Rajiv now. Now, which is the best sample of urine to be collected for the osmolality?
I didn't understand that.
The question was, it's written, which is the best sample for urine osmolality? Best sample that has been asked. I think so. It's like the first morning sample that you need to collect, or the
Yeah,
second.
ideally, that's what we do. No, like first morning sample. That's
First
what
morning.
we. Advantage is that you are also subjecting the child to like what sort of water deprivation.
Water deprivation. Then another question by Dr. Suman Raut, like how do we do a water deprivation test in a child who is just 2 years old and has a creatinine of 0.8? That means a deranged creatinine is there, renal function. So whether water deprivation test should be done in such children or not?
So the first question, so if the question is that whether water deprivation test should be done in children or not. So obviously it can be done, and it is done in children. After all, we are pediatric nephrologists, so we are doing it. Whether it is needed or not is the most important question. And many a times, most of the times we don't need it. Even in our child also that we described, I think I did say that we didn't do the water deprivation test because the child was already water deprived. Already the child was having a high sodium. Already the serum osmolality was on the higher side. And I believe that's where often the mistake happens, that you start water depriving a child who is already dehydrated, then you ask for trouble. And secondly is that it has to be, it should not be taken lightly. I mean, I'm sure all of us do in the same way, that we have a strict protocol with in fact very small child, we go for every half an hour wait. A bigger child like 2-3 years, at least hourly weight, and then a cut off that below this weight you stop.
So basically, this question would have been better framed as a prerequisites to do a water deprivation test. Yeah. Then there was one more question from Dr. Arpita, like why is there is hyperuricemia in children with Bartter syndrome, for Dr. Sriram?
So this is not so common in children. Adult patients are known to have gouty arthritis, and this is basically because of the volume depletion and the metabolic alkalosis, which leads to poor renal clearance of the uric acid. It's mostly an adult complication. It's not reported as much in children, I think.
Even simple dehydration can cause hyperuricemia.
Yeah.
So any of the delegates or any faculties want to ask any questions?
So I have a question for Dr. Sriram. Excellent talk, Dr. Sriram. That has been, great to hear from you after so many years. So thank you for coming and giving the talk. The question I have is regarding the end-stage renal disease in Bartter syndrome. And you nicely quoted the two studies that, yes, I mean, it is there, and that is something as a pediatric nephrologist, we should be always watching for. And we know that chronic hypokalemia can lead to long-term renal injury, and use of NSAIDs can lead to long-term renal injury. The question I have is regarding renal transplantation. And sometimes the trainees ask us that this is a genetic disease. Do we expect this to recur in a transplant patient? So does Bartter recur in transplant patient or not? That is what you can share your thoughts about.
So this is, most varieties are autosomal recessive. So if you have from a live donor, a live related donor, then I don't think it's like, it would be a carrier only, no? It won't be having the, a carrier won't be having the symptoms. So I don't think it will be recurring. I don't think, unless it's an dominant variety like the CASR mutation, there you would expect. But in an autosomal recessive, if a donor is, they may be expressing slightly lower amount of protein, but not enough to cause the disease, perhaps.
Yeah, no, I think, as we know, the literature is not very clear on the living donor part of it, but deceased donor, that's what, at least we prefer here. That if we do have a Bartter syndrome, then we prefer a deceased donor, and then the recurrence risk is not there. So definitely when there is a living donor, then genetics does play an important part. And as you mentioned, that depending on the kind of mutation, it may determine whether there is a risk of recurrence or not. I think we are still learning about this. And
for a living donor, I'm sure we will then evaluate if it is from the relative. Actually, we are lucky that most of the time we don't see Bartter going into ESRD and transplant, and those who go into ESRD and transplant, we leave it for the adults.
I have a small view. See, of course, it's a disease confined to the renal tubules. It's not a systemic thing affecting the kidney. So if you take off this kidney or you put a nice kidney, that's going to function. There's nothing systemic to affect the function. It's only local functional disorder. I think it's safely give. But in fact, I have a boy who I'm seeing for about 3 or 4 years. Now he has gone for a renal transplant because he developed severe nephroconsis with CKD. His mother donated. It's comfortable. I do think that there's a contraindication for it as in other diseases. What is my view about that? Would you agree, Dr. Rajan?
Yeah, definitely.
Yeah, no, I think that sounds very right. And here I have actually 3 kids in a family. All 3, there were 5 in a family. 3 of them have Bartters. And the oldest one, he was the non-compliant one who was, missing his medicines. He did go into end-stage renal disease, and we transplanted him. And definitely he did not recur. He's 2 years post-transplant. The middle one has some CKD element going on. And again, we have been trying to be, very aggressive with the potassium management, making sure that hypokalemia is well controlled. And the youngest one has normal renal function. So I think as we are seeing more, patients with these and having more long-term follow-up, the CKD is something we should keep in mind. So I think it's an excellent question that, how common do we see CKD, and that should be closely monitored.
We would be seeing, as rightly pointed out, a boy who is not compliant among the 3 boys, otherwise the patient I have referred also is not compliant. He's studying in India. His parents were somewhere in Dubai. So the boy was out of control, so he couldn't come. By about 15 or 16, he went into it. Another contributing factor in this is nephrocalcinosis. So another thing which contributes a lot to the renal damage. It's not only the hypokalemia, it's also renal, and plus the other aspect, dehydration, other stuff.
Yeah. And then the use of NSAIDs, I think, the longer we use the indomethacin, I think that causes further injury as well. That contributes also to the dehydration, that contributes to the long-term renal injury as well.
Yeah, if I may say so, it is quite difficult. Like we have under 4 or 5 cases of Bartter, of which one I've been following for the last 10 years. Now is moving on to adults, and so always the parents used to say that you are following up this child regularly. What are you doing? You are just monitoring the electrolyte, but they don't seem to improve. If you increase the potassium, he starts vomiting. If you increase the indomethacin, then she starts having a pain in the tummy, or his creatinine goes up. Then you bring it down. So it is quite a long process, and the family has to appreciate that. And he ended up like when I transferred him to the adult, he had a creatinine of 1.3. So I'm sure that he will go into the full CKD and transplant in future.
Another problem and complications is the breast engorgement because of the aldactone. These boys, they don't like to take the tablets. It causes a lot of engorgement and pain for them. So that's one of the rather frequently met difficulties in managing these boys as they grow up.
Yeah, and then, again, to avoid the aldactone, we do tend to use amiloride here. Besides the indomethacin, we try to use amiloride more common than the aldactone.
So again, then you have got that worry that which Dr. Siram pointed out, that if you are using more diuretics, then also and then in this particular child, because of the hypercalciuria, I did something which I shouldn't have done. I even used a bit of thiazide for almost a year, and Detlef then went ballistic. Although the hypercalciuria decreased, but I mean, the bottom line is that I don't think there much can be done apart from the conservative therapy. And in India, I don't know what is the experience of Kanav, Kalaivani, or Siram, but follow-up is also quite difficult. They slowly lose interest.
Basically, I'd like to ask Dr. Sriram regarding this follow-up only. Do you have any children who have got off the medicines over a period of time?
No, no, never.
No.
We have not seen major 2.
Because
we've not seen major 2.
I had a genetically confirmed Barters, slightly poorly compliant, had potassium something around 2.93ish. So with over a period of time, he stopped all his potassium supplements. He said, I drink a lot of coconut water, bananas and all. So I maintain. So I said, okay, continue the indomethacin part. With time to come, he stopped that as well. And now like if you see him, everything seems to be fine. So the question, as Dr. Rajiv has already told, that what are you actually doing? You're just increasing the dose, decreasing the dose, and patient says, I've stopped everything and everything seems to be fine. I don't know how things are going to work up in future, but he stopped all the medicines.
Hope the GFR is fine.
A GFR is fine. It's almost 0.7 to 0.8.
Yeah, see, I think non-compliance is universal, whichever part of the world you are. I think all of us struggle with that. So
another question was regarding nutrition in your in the newborn phase, because they tend to pass a lot of urine. You're giving a lot of the feeds and all. But how do you take care of the nutrition, especially in the infancy for Barters?
How do we take care of
the nutrition part? I mean, especially the feeds part. How do you basically increase the calories in the feeds? Have you ever done a?
No. I have we called for management of shock and hypovolemia, and I think that's the priority. Breastfeeding keeps on going on.
So like
it goes on, but
we have used the gastrostomy. Yeah, we have used gastrostomy even in India also. In a couple of children initially needed that.
Was in the neonatal period, like the child was passing huge amount of urine. So initially a lot of NG feeds used to be given, but the question was how to get him off the NG feed and finally send him home. So finally a plan for gastrostomy was done, but the parent decided against the gastrostomy. They said we will continue to feed the child via the NG feeds only. And over a period of time it's improved. Yeah,
and that is another thing. For example, we had the NDI too, and then that also in the newborn period, often they would benefit from gastrostomy because they drink so much that they don't have space for nutrition. So both Bartter, polyuric, NDI. But in India, if you say that you are going to make a hole in the tummy, then there's 90% chance that the absolute calculus is 90% chance that the next day they will be either be with Dr. Kalaivani in south or with Dr. Kanav in north. That वहाँ का doctor said to make a hole.
Acceptance is very poor for gastrostomy. Yeah. So the peg tube.
Whereas in the UK, many of them were having gastrostomy, at least in the initial part. In India, like I've been able to do it in 4 or 5 maybe.
I can share my experience from here. So definitely neonatal management is very challenging. No question about it. I think to give nutrition to such a polyuric child, they stay in the hospital for a very long time. And once, the NG feeds is the most appropriate, at least in the neonatal period. We wait for them to be at least 5 kilos before we can bring up the idea of gastrotomy, G tubes. Meanwhile, we also try, if NG feeds don't work, we try NJ, like going to all the way to the jejunum and seeing to feed, give volumes there as well, trying to give continuous feeds rather than more like bolus feeds. I think those things help in the neonatal period, but ultimately gastrostomy tube is something we really push for, uh, not just for the feeds part of it, but also for the management of electrolytes. So, these kids would be on a lot of sodium supplements, as we know. Even taking potassium itself can, there's so much liquid potassium you can give orally. So that is how we try to push for the gastrostomy tube. Then even for indomethacin, giving through the G tube, it becomes easier. Even if you're using amiloride, it becomes easier. So we say that it's not just for the nutrition part, but also for the medication part. And I think that helps sometimes families, buy into it. But yes, neonatal is really, really challenging when it comes to giving nutrition. And I would think NG feeds is the best way to go.
Dr. Kanav, we are done with this.
In case there are no more questions, we'll try to wrap up then.
Yeah.
So over to you, Dr. Kalevani, in case you want to give your final comments.
I just have one small doubt. Dr. Sriram, what is the maximum oral potassium load you can give?
Orally.
Orally. Oral potassium supplement, what is the maximum dose?
I could not find any literature regarding what is the maximum we can give.
Okay.
People have used up to 10 milliequivalents per kg per day also. That's what I saw in some of the, but it's not like universal. It varies from child to child. Bartter syndrome type 2 will have the least potassium requirement. They have the best potassium out of all of them. And it may also come down with what you give additionally. Maybe if you give spironolactone, the demand of KCl may come down, but then there's a controversy in using it. You are blocking the aldosterone.
Okay.
I think it depends on the tolerance, and the other thing is that we, as we all know, that we should never target a normal potassium. I mean, that is often not achievable also. So anything above 3.2, I think we should be happy.
Basically, in reality, the maximum dose, it's basically the problem is not that how much dose you are giving, it's actually the tolerance. At one time, the child will start puking out. He said, like, we cannot.
As well as how much they are taking. Because I remember a child recently only, a Bartter. So they were going on increasing, like potassium low, go on increasing. And then one day, the mother said that, sir, like whatever I am doing my work of increasing, she is not doing her work of giving that much. So, and she said, how can I give? So we went to 4 hourly. Sorry, 3 hourly. I think I shouldn't have done that. I went to 3 hourly potassium supplement. And she then said to me one day clearly that, how do you expect me to give 3 hourly? And then I realized that no, it was my folly.
There's another thing when there could be accompanying hypomagnesemia that may also contribute to the
very important.
So if there's uncorrected hypomagnesemia, that may add to the demand of the, you may keep on increasing potassium without looking for the magnesium problem.
That is a very important point, and that is a very important point for our day-to-day practice also. Like if we are dealing with refractory hypokalemia, then we should always be looking whether there is the low magnesium.
The other question I also feel is important is, when are we checking the labs? Because we put these kids on potassium supplements like every 4 hours or every 6 hours. So how do you time the labs? Do you do a trough potassium, or do you do like a peak potassium? How do you, and how do we do it each time consistently? I think that also matters a lot. I don't know what your experiences are about it.
Yes. definitely. Like when you are doing it, and then there has been reports of parents say missing few doses, but then just before the blood investigation, catching up like on the potassium, and that can also be erroneous.
It's a very challenging disease.
That's why I like that distal RTA. Distal RTA, most of the time, like I can hardly remember of a distal RTA where like a long-term management has been difficult. Most of the time, once you start with a good amount of phosphate, they do have a good response, growth and everything.
I think we should have separate reference ranges for potassium in these children. Something like when you see Turner syndrome, they have separate growth curves. So something like that, you should perhaps aim for 3. 3 is a very, very good thing, perhaps.
Yeah, that's what I said also. Like, if we are achieving 3.2, we should be happy.
Yeah, between 3 and 3.5, I think that's the most you can go up to. So,
Go side of normalcy.
I think we'll wrap the session if everything is fine. I think Dr. Namalvar sir has already left.
Yes.
Like the next session will be on July 23rd, and we have the interesting topic on renal tubular acidosis and tubulointerstitial nephritis. And we'll have the polling session as well on July 23rd.
Thank you.
Thank you.
yeah,
So much.
thank you
Thank you
all.
very much.
Thank you, Dr.
Thank you,
Rajesh.
Thank you.
Thank you, Dr. Rajiv.
Bye.
Thank you, Dr. Karnav. Good
Bye.
meeting you all. Thank you.
Thank you. Bye.